let's move on to our second presentation, which will be provided by Dr. James Korte. He will be sharing with us on magnetic resonance biomarker assessment software, an automated open source tool for the ISMRM NIST system Phantom, which is perfect answer to our second question here.
Oh, big thanks to the first speaker for opening up the discussion about quantitative MRI and getting people thinking about reproducibility. My talk is about a software which we made to analyze phantoms, which are used for quality assurance. But the motivation for that is really coming from, I work in a cancer center, and quite often our biomarker trials are split between multiple sites. And with that comes a lot of challenges around if you're getting images from different types of MRI scanners, how do you have some surety that you're getting similar quantitative values, and how does that impact your trials? So I hope that we can touch on, I guess, some of those points and get some discussion going as well. Just to disclose, the Fast Track 2 trial, which I'll be using as a case study, and its imaging sub-studies is supported by Varian. And we also have a software agreement with a company that we use for some of our DCE analysis. So I'll start off really just by talking about this case study, which is a multi-center imaging study. And hopefully that'll provide some context for why we actually wanted to make this software in the first place. I'll then introduce the software, a bit about how it works, and then also how we've tested it to demonstrate its efficacy or accuracy. And then I'll talk a little bit more about where we're hoping we can take it in the future. And it is an open source project, which we already have some collaborators working with us. So I'm hoping that today some of you might be interested in using that as well and can help us develop it and make it more useful for a wider user base in the future. So from my perspective, working in a cancer hospital, and in particular a radiotherapy department, there's an increasing use of MRI and radiotherapy, and that's due to some technological changes. And this really provides us an opportunity to translate some of the MRI biomarkers in the oncology space as we have more imaging data than we previously have. But to actually translate these biomarkers requires some technical validation. And by that, I'm talking about kind of those quantifiable numbers in an image. And that's often achieved with a reference phantom. And that's looking at assessments of repeatability, reproducibility, and bias. In particular, in radiotherapy, the biomarkers which seem to get a lot of attention are dynamic contrast enhanced MRI, because it's a surrogate for microvasculature changes, and diffusion weighted imaging, which is generally considered a surrogate for changes in cellularity, so how many cells there are in a tumor. Or damage or changes to the cell membrane itself. So let's jump into the case study. This is a clinical trial, a phase 2 trial, which has been running over, I think, about the past 4 years now. We're just kind of getting to the analysis phase now. And it's looking at giving stereotactic ablative body radiotherapy. So this is a high dose of radiotherapy given in a single session. And that's a treatment that is being offered for patients who come to us with kidney cancers, and that for other reasons they're not suitable for getting an operation or surgery, which is kind of the primary care at this point. Earlier this year, the primary outcome of that trial was announced at ASTRO, and that demonstrated that for the participants in the trial, 100% of them had freedom from progression at 2 years. So it's emerging as quite an effective treatment. But there still remains some challenges around assessing response. So the way that we look at if these patients have responded to their therapy or not is by looking at how their tumor changes shape, and we do that on CT, and it can be quite slow. So sometimes we have to wait, 12 months or longer to actually determine whether these patients have responded to therapy, if their cancer is just kind of staying at the same size, or if they've got maybe a tumor which is a bit more radiation resistant and it's starting to increase in size. So whilst these shape changes are really slow, we would expect that there should be some earlier functional changes because we're delivering quite a high dose of radiation. And that asks, poses the question, can we observe some of these early changes to vascularitary or to the cells themselves by using a different imaging modality? And in particular for this sub-study, it's using MRI. And that's kind of the basis for this Fast Track 2 MRI sub-study. And essentially what we're trying to do is look at an early time point. So in this case, 3 months after the therapy on MRI, and then trying to say, okay, does that correlate to some of these later size changes, which we wouldn't see until 12 months or 24 months, so an early response biomarker. And we are looking at diffusion-weighted imaging and dynamic contrast-enhanced imaging. And we did have a previous pilot study which motivated some of this work as well, where we did see those correlations. You can see along the bottom there that we take CT and MRI at baseline. The patient gets their therapy. 3 months after therapy, they go for an MRI. And then their CTs, their follow-up or surveillance CTs, start at 6 months and roughly every 6 months. And those actually continue for the duration of the patient's life. So that's quite a burden, and also an additional radiation dose, which they have to go through for surveillance imaging as well. The data which is used in this trial comes from 3 different cancer centres around Australia. And with that, obviously, comes the challenge that we're getting MRI imaging from, I think it's maybe 4 or 5 different MRI scanners. From that, you can see that we still have relatively low sample size. So for the diffusion-weighted imaging, that's about 6 to 11 patients. And for dynamic contrast-enhanced imaging, 5 to 9 patients. So the reason why you would split one of these studies across multiple hospitals is because this might be a quite small patient group. And if you tried to do it just at a single hospital, the recruitment might take, say, 10 years. So if you can get more hospitals on board, then you can actually get this data quicker, and also within a time frame that, say, technology isn't changing or treatments aren't changing. For the diffusion-weighted imaging, we did pretty stock standard EPI spin echo. You can see the B values there. We used image-based respiratory gating. So I guess when you're outside of the head and more looking at the torso, motion becomes a real challenge. The apparent diffusion coefficient maps, these are really basic. They're just mono exponential ADC maps, which we've taken straight off the scanner. And the reason why in a cancer, or I guess the way that we think about this in an oncology or cancer setting, is obviously DWI gives us insight into tissue microstructure. So you can imagine if you have a really dense, high cellularity tumor, there's not much space for the water to move around. So it's quite restricted, the diffusion, whereas if we have cells which have damaged membranes, or there's a lot less cells, then the water should be able to move around a lot more freely. For the dynamic contrast enhanced imaging, we acquire this with a fast 3D volume sequence. We use T1 weighted twist. And you can see with this allows us to look at the injection of intravenous contrast agent, how that moves around the body. And in particular, we're interested in how does this get taken up into the tumor in the kidney, and then also how is it cleared from that tissue. And for that, we use an oblique coronal slab, as it allows us to cover the affected kidney, but also the aorta. And from that, we can get a patient-specific arterial input function. We take these for a roughly 6-minute duration, and the temporal resolution is around 3 seconds. If we then consider just one portion within the tumor, or one voxel, we get what's known as a DCE signal, or this contrast uptake curve. And you can see that it starts with that's shown on the left, that starts with a relatively low signal intensity. As the contrast agent comes in, there's a big spike. And then as it's cleared from the tissue, we get this slow decrease in intensity. So for each voxel in the tumor, we can fit a range of different models. We've fit 2 semi-quantitative models, a piecewise linear model, and just a categorization into 3 curve types. And then there's also a quantitative model, and we'll use the extended TOFS model. From each of those models, we can then generate a series of parametric maps, and then we can assess those just within a tumor volume. We then correlated these to CT volume changes, and we did that using Spearman rank test with a significance of 0.05. And what we looked at was, how does the MRI change from baseline to 3 months, and then how does the CT volume change from baseline to each of the follow-up time points. The CT volume itself is estimated as a spherical volume, and that's based on 3 width measurements from a radiation oncologist. So we did find statistically significant correlations for some of the DCE metrics, in particular VE, which comes from the quantitative model. So the changes between VE from baseline to 3-month MRI correlated to CT shape changes at 6 months, 12 months, and even out to 33 months. And from the piecewise linear model, we had a number of different metrics which correlated to those later changes on CT volume at 9 months, 18 months, and 33 months. If we look at one of those a little bit closer, so in this case, I'm just showing VE, the extracellular extravascular volume fraction. You can see that there's a clear trend there between the change in volume at 33 months on CT and the change of VE at 3 months on MRI. So we're getting a correlation between something at 3 months to past 2 years. And if we then look at 2 of those patients, you can see that along the top, we have a partial responder. So on their 3-month, so I've just got an overlay there of the VE map on the kidney zoomed in. And you can see that the VE is increasing at the 3-month time point, and that correlates to this later decrease in volume or a shrinking of their tumor at 33 months. In comparison, if you look at a participant with stable disease, their VE at 3 months is actually decreasing. And if you look at the volume of their tumor on CT over time, it remains relatively stable. There's not much change, indicating that they haven't responded very positively to treatment. Well, keeping the tumor in the same condition is actually considered a benefit, but they haven't had a full response. So from that, we can say there's significant correlation between DCE and later changes in CT volume. We did see some trends for diffusion-weighted imaging, but there was nothing significant. And of course, due to the quite small sample size, these findings are all considered exploratory. So, I mean, that's the case study. And I think I've probably already talked about the motivation for this enough, so I might just skip over that. But what I guess I get from this so far, even though we haven't fully completed the analysis, is, you know, why didn't we see any significant trends in the diffusion markers? There is just the possibility that there isn't a trend to be seen. Maybe that there aren't changes in diffusion for kidney tumors in relation to this high-dose radiation therapy. But a question which we have as well, it might actually be due to the fact that there's some variability between the diffusion values, which we're getting from the 3 or 4 or 5 MRI scanners, which are being used in the trial. So for instance, if we look at this, it's the ADC ketosis at 3 months, how it's changed compared to 2-year changes on CT. And you'll notice that if we just looked at scanner 1, which are the purple dots, you know, it looks like a pretty good linear trend, but then we've got scanner 2 there with one participant who's really not fitting that trend. So, you know, is there potential that maybe there's some difference in the way that we're measuring ADC on that scanner? And if that point was sitting down there, then suddenly we have something that's looking like a significant trend. Similarly, for the DCE markers in the pilot study, one of the markers which was significant was K-trans, but we didn't see that in this follow-up. And I should say as well that the pilot study was a single center, single scanner study, so there was no concerns about reproducibility. So again, you know, maybe there just is nothing to see there, and the pilot study might have just been something which was, I don't know, due to some other factor. But it also might be that there's some variability between the scanners. So again, if we just looked at scanner 1 and scanner 2 for K-trans in this plot, you know, you could say that, well, there's a little bit of a trend there. Maybe it's not super strong, but then scanner 3, this red point, does kind of sit outside of that a little bit. So potentially, you know, if this was sitting a little bit lower, maybe we would start to be seeing a trend. So what can we do to improve? I mean, these are just examples. The data that we're looking at might actually be correct, but I guess we have this overarching question or doubt in our data sometimes that we can't actually guarantee that we're getting the same numbers from different scanners. So what can we do to try and improve that? And that's where MRI phantoms come in. So phantoms in general are these you know, objects with known properties that allow us to take, I guess, a controlled measurement between different scanners or over time on the same scanner to make sure that we're actually getting the same values, because we can guarantee that the object isn't really changing over time, or not very much. I'll talk about 2 phantoms today. So this first one is a diffusion phantom. So it's used for doing quality assurance of diffusion-weighted imaging. And it's got these different compartments in it, which have different concentrations of PVP, which generate different isotropic ADC. The diffusion is temperature sensitive. That's well known. So I think the older version of this suggested that you use an ice water bath to control the temperature, but the newer ones actually have an imaging visible thermometer, which allows you to do that without having to play around with ice water and the challenges of that. The second phantom, and the one that the software that I'm going to talk about is based on, is this NIST ISMRM system phantom. And this has actually got a range of different things in it. It's meant to be able to check quite a bit of the scanner parameters. So it's got geometric things such as these resolution inserts or slice profile ramps. But for what I'll be talking about today, which is more quantitative imaging, there's also these arrays of T1 and T2 vials or spheres, which have different chemical doping to change their T1 and T2 values. So how do we actually use these phantoms for quality assurance? So they have, in my mind, kind of two main uses. The first is during the setup of a multi-site or multi-scanner clinical biomarker trial. So one thing that you can do is, the previous speaker kind of alluded to, is you can just try and use the same imaging protocol across all of your scanners on your trial. But you still might want to test that you are getting the same number. And quite often during setup, it's easy to have one of your parameters entered slightly incorrectly. So it's been demonstrated that these phantoms can help with things like that. Or additionally, you might have a much better scanner at one of your sites than the other, and you don't necessarily want to use the oldest sequence that you have available to you. You might actually want to use one of the newer sequences. And it's been demonstrated that you can also use these phantoms to be using different image acquisition protocols at different sites, but still have some surety that you're getting similar quantitative MRI values. And in addition to using these during setup, there's also the ability to use them throughout the clinical trial. So they have been demonstrated that they can detect changes in scanner performance or configuration over time. So sometimes your MRI manufacturer will come in and do a service, and they might change some settings. Or there might just be some damage to your scanner over time, such as one of the coil elements in one of your coils getting broken or a bit degraded. And this type of ongoing measurement throughout your trial, which might run for 2 or 3 years, can allow you to pick up some of these things and ensure that your data is actually good or consistent throughout the whole trial. So yeah, I think phantoms are great. They allow you to test some things and also to develop things, but there are some challenges with using them, and that comes mainly on the side of you need some software to analyze the quite large imaging data sets which you can generate with these. So what a lot of people do is write their own scripts. That's what's commonly done in a lot of publications. There is an open source software which is called Phantom Viewer from NIST. And there's also commercial software. So quite often when you buy one of these phantoms, it'll come with software. But that's generally maybe a license for a year. And quite often they fix that to a single scanner. So, and you have to pay per scanner then to get new licenses. So it can become expensive quite quickly. So Phantom Viewer is quite good, but it is semi-automated. So it requires you to manually place the regions of interest for analysis. And that can introduce a little bit of inter-observer variability. And it also requires the manual selection of your imaging time sets, and that can actually be quite time consuming if you haven't taken care to keep them ordered during acquisition. So essentially we developed a fully automated solution, and with the aims of reducing inter-observer variability and also making the analysis quick and easy. And with that, I mean, we want to use it on our own multi-site clinical trials, and we thought it would be good to share the tool as well. So it's called MRBIOS, which stands for Magnetic Resonance Biomarker Assessment Software. It's fully open source. It's available on GitHub. It's written in Python 3, and we really tried to build this with ease of modification in mind. So it's fully object-oriented design, and it follows extensibility principles. So we built it with this idea that, okay, well, we're making it for the system phantom, but it should be pretty usable for other phantoms as well. Well, and to go over the main steps that it performs, essentially, you point it at a directory or a file of DICOMs on your hard drive, and it does these 3 main steps. So it first sorts your images into different image types. It will then do region of interest detection, so pick up each of these regions which you want to analyze, and then it'll fit a T1 or a T2 model to it, and then output some values. The whole image analysis process is also governed by this configuration file, so you can kind of select different things, like if you wanted to use different relaxation models, and it outputs a PDF, so a visual report that you can look at, and then there's also all the numbers get output in more of a data file or a comma separated value file if you wanted to do some other analysis or plotting across maybe multiple image sets. So I'll just run through some output from each of those. So this is from the PDF report, just showing the different images which which MR Bias has found in the DICOM directory. So it uses the DICOM metadata to pull out each of these different image sets. You can see it's picked up a geometric image, a couple of different variable inversion recovery data sets, some T1 variable flip angles, and also some T2 multi-spin, multi-echo data. And you can look at that and make sure that you're kind of getting the images which you're expecting from the scan that you've run. The way that it does region of interest detection is using an atlas or template-based method using rigid registration. So essentially we have a template or atlas image which we've manually put on where the regions of interest are, and we just take your new image and register it to that, and then we're able to propagate the regions of interest across, and you can see that it's able to detect those on the right-hand side. In the PDF output, you can also kind of check this, especially if it's a 3D scan, to make sure that they've actually been placed in the right locations. And then once we've got these regions of interest in place, it's possible to then fit these different relaxation models. So this is an example of a T1 variable flip angle fit. You can see that the solid points are the measurements that have been taken, and then the solid line is the curve fit. And the way we do the curve fitting is using a nonlinear least squares optimization, and that's using this other open source Python library called LMFit. You might notice as well on there that we've got some other indicators. You can exclude measurements if you don't want them included in that fit. And then also sometimes due to not setting up your scan quite correctly, you might end up with saturated or clipped values as well. So we have some automated, I guess, detection of that as well that you can turn on and off. This is an example of the output that you would get from a model fit. So this is in the PDF, just showing a big table of your different T1 values per region of interest. It also shows the signal model that's been fit there with a little bit of a description of each of the parameters. And as I said before, these are also output in a CSV file, which would allow you to do any subsequent analysis. We also visualize percent bias, which is really what you're interested in when you're trying to do these type of technical validation studies. And that just looks at how far, or as a percentage, does the value that you've measured deviated from this NMR reference value that's been provided by the manufacturer of the Phantom. And as you can see there, for all the biological ones, which are kind of ROI 1 to 11, we get really good agreement between the two. So how much can you trust what's coming out of the software? We did some testing to have a look at this and make sure that it was working properly. So the most important thing here is actually the last point, are we accurately quantifying these? Because you don't want to be introducing another source of error with your software. But we also wanted to look at, okay, well, did this software that we've made actually address the other points which we were trying to address, which are, does it reduce inter-observer variability, and does it also reduce the analysis time? So we did a volunteer study where we just got 6 different people to use not only MR Bias, but also the Phantom Viewer software, which is the other freely available software at this point. And we compared inter-observer variability and also the task duration. So you can see here that for Phantom Viewer, it was shown in white, and MR Bias in purple, that we are getting a lower inter-observer variability using the automated tool. And I think that's largely just coming from the fact that the regions of interest are always going to be in the same spot, whereas when you have people placing them, there can be a little bit of variability there. For time efficiency, MR Bias was approximately 10 times faster. And as you can see in these plots, that time difference is really just coming from the time that it would take for the manual placement of these regions of interest. In this test, though, we actually had pre-sorted all the images into separate folders as well. So I would probably argue that you probably get an even bigger time speed up by not having to do that yourself. So what about accuracy? To address this, we got a longitudinal MRI data set from an existing study. So we just collaborated with somebody, and they'd taken a longitudinal data set. So scanning the same Phantom on the same scanner over 12 months every month. And from that, we calculated T1 and T2 times with our software, and then just compared it to what was in their existing publication, which was done with a custom script. And essentially what we saw from that is that we have the same accuracy. There's no significant difference in the overall bias of the T1 and T2 relaxation times within the physiological range, so the ones which we're interested in the human body. So the software at this point is really only mainly been tested on data from Siemens scanners. We did also run it on some Philips data that's come out of an MR-Linac. It supports a range of relaxation models for T1 and T2, and we do have a couple of different registration methods depending on what data is available. In terms of, like, we generally like to take a big 3D isotropic image to do that registration, but other people haven't always had that, so sometimes we're doing it more to a 3D slab. And it currently supports the system phantom, but we are actually working, we have it now working on a diffusion phantom, but we're just doing some of this accuracy checking before we kind of do a more general release of that. And I guess what I'm trying to show on this diagram, I don't know if you can see my mouse, but you don't need to be able to understand this diagram really, other than to know that wherever there's a green box is where we've made it really easy to add something in the software. So if you want to put a different type of relaxation model, it's very easy to add that in. And again, it was relatively easy for us to add in a different type of phantom as well. So to conclude, I think phantoms are a really important tool when it comes to trying to do quantitative MRI in a multi-scanner or multi-center context. We've built this software to help us in our clinical trials, and we hope it can be useful to others. At the moment, it's for T1 and T2 quantification. But I hope probably in the next 6 months that we will have fully tested the diffusion aspect of this as well. And we're actively maintaining the software, and we have a couple of collaborations already with centres in Australia and New Zealand. If other people are interested, please just get in touch with me, whether that's just to set it up and try it on your own data, or if you have any issues. And that's, yeah, I think I'll wrap it up there. Thanks a lot for listening, and I'm open to any questions.